sharing the screen for a minute. Dr. Rajesh introduce and then you can share the screen.
Go ahead, sir. You can start.
Okay, so welcome to this third case session this year, this new academic year. And this time we have a hematology case, and Dr. Ajit from Srimati Kashibai Nole Medical College, under the guidance of Dr. Tushar Deshpande, is going to present the case. And as faculty, we have Dr. Aarti Kinikar Madam, who is Professor and Head of Pediatrics at BJ Medical College and Sassoon Hospital. And we have Dr. Lisa Balsara, who is a pediatric hemato-oncologist. She is attached to Jupiter Hospital and she runs free thalassemia clinic also. So I welcome on behalf of IAP Pune, the faculty. And I think without much ado, let us start the presentation. I request Dr. Ajit to start the case, please.
Yes, sir. Sir, my slideshow is visible to you?
Yes, it is visible.
Ajit, make it full screen, slideshow.
Yes, yes. Shall I start, sir?
I think you can begin.
Yes. Informant is mother, reliable, 12-year-old male child, firstborn of non-consanguineous marriage, Hindu by religion, Banjara by caste, residing at Kothurud, Pune, was brought with the chief complaint of easy fatigability since 7 days, paleness since 5 days. Date of admission was 6 March 2022 and date of examination was 6 March 2022. Instead of presenting illness, patient developed easy fatigability in the form of he was not able to play with the peers, which was progressive in nature, that he is not able to do day-to-day activities, and he was relieved and it was relieved on rest, which was noticed since last 7 days. Mother also noticed increased paleness more on palms and soles. There was history of decreased appetite also. Negative history. There is no history of cough, rapid breathing. There is no history of palpitation, syncope. There is no history of fever. There is no history of melena. There is no history of fresh blood in the stool. There is no history of hematuria, petechiae, purpura. There is no history of yellowish discoloration of the skin. There is no history of edema. Past history. At the age of 9 months, patient was admitted with the complaints of increased paleness and decreased oral intake with poor weight gain. Child was admitted for 8 days and diagnosed with some hematological disorder, received 1 blood transfusion. Mother was counseled regarding the disease and regular requirement of the blood transfusion. Since then, the patient was on regular blood transfusion. After 2 years of the transfusion, patient was started on oral tablet, which was advised to take on empty stomach. Patient was not taking regular medication and was stopped since last 2 months on its own. Transfusion history. Over the years, gradually the transfusion requirement is increased. Sometimes 2 bags required every 15 days. 9 months back, patient had history of fall while playing, developed swelling for which cast was put. During this admission, he received 3 blood transfusion over 3 days. Birth history. Antenatally registered iron folic acid tablet was taken. Ultrasonography was done normal. Natal history full term normal vaginal delivery. Baby cried immediately after birth. Postnatal not significant, not contributory. Immunization history as per the national immunization schedule, it is incomplete. BCG scar is present. Hepatitis B vaccine and polio vaccine was taken. Immunized till 5 years of age. No special vaccine received as per the IAP schedule. Developmental history, initially there was some gross motor delay during the infancy, but later on she achieved all milestones as per the age. Family history, there is non-consanguineous marriage, no history of similar complaint or blood transfusion in the family. Dietary history, total calorie intake is around 1210 kilocalorie and 19.5 gram of the protein, with the calorie deficit of 900 kilocalorie and 20 gram of the protein. This calculation was done as per the ICMR guideline. Socioeconomic status, according to the modified Kupuswamy scale, patient is upper lower class, score was 10. Summary, 12-year-old patient with complaints of easy fatigability with history of regular blood transfusion on oral medication since 3 years of the age, which was irregular, with left ankle swelling since 9 months, developmentally normal, without any significant family history, probably the case of transfusion-dependent anemia. Sir, should I continue with the examination?
No, can you just, Dr. Ajit?
Yes, ma'am.
Yeah, can you just tell me, for a 12-year-old child, what are the common causes of easy fatigability?
Ma'am, there may be chronic anemia, there may be chronic respiratory tract infection, there may be neuromuscular junction involvement.
So neuromuscular will have easy fatigability.
Fatigability
Can you
on
give some examples?
such as myasthenia gravis.
How is the fatigability of myasthenia gravis?
Fatigability on exertion, doing day-to-day activities.
So how are they in the morning and how are they in the afternoon or evening? Myasthenic patient.
Sir, in morning, the patient, there is no fatigability. When they do day-to-day activity, fatigability get increased, and after taking rest, fatigability decreases.
Correct. So this is not, we are not suspecting really
Yes.
neuromuscular here, isn't it?
Yes.
Can it be a muscle issue?
Yes.
Myopathy of some kind?
Can be, sir.
So why it is not a myopathy then?
Sir, the course is fatigability is since last 5 days. There is no history of the patient is able to walk. Patient is, there is no disability, and the age of the child presenting this fatigability is also 12 years.
So myopathy is essentially an acute disease or a chronic disease?
Sir, chronic disease.
Chronic disease, and it is characterized by progressive
Yes.
weakness of the muscle,
Yes.
isn't it?
Yes, sir.
So here you have a history of transfusion also.
Yes, sir.
Regular blood transfusion. So if a 9-month-old baby comes to you first time and you find the baby is pale and in your opinion requires the blood transfusion, what are your thoughts?
Sir, at 9 months, if baby comes with the paleness, there will be nutritional anemia first, because the complementary feeding started, and weaning of the breast milk is also, if not done, or cow milk feeding is done, there may be cow milk allergy also. So, iron deficiency anemia is the first differential diagnosis of at 9 months of age.
Dr. Kinika ma'am, can you elaborate a little bit on this? And Dr. Lisa, both of you, a 9-month-old child coming for the first time with requiring transfusion, anemia requiring transfusion. So what possibilities and how do we evaluate at that stage?
Okay. Actually, we are still on the history, so I was more concentrating on the symptoms. So whenever you say that it is fatigue, fatigue is the word to be used in exam when a person feels tired after doing some activity, the person stops the activity, takes rest, and regains the energy to work. So that is how you will use the word fatigue. There is another word which is used wrongly is gets breathless. Okay, it is taken synonymous with becoming fatigue and then having breathlessness. So when you're presenting a case, you should know a 12-year-old, forget the other history. If you are just sitting in the clinic and this patient walks in at the age of 12 years, you should know at 12 years what are the causes of easy fatigue. So primarily you should look at anemia, hypoxia. The second one is the cardiac involvement, where the rest will improve. The third is the respiratory, but the fatigue of respiratory, usually you will have some amount of breathlessness. Same thing happens with the cardiac. So if an examiner asks you that what are the causes, these are the three. First will be the anemia, hypoxia related fatigue. Then there is an underlying cardiac problem where you exercise or you work and then you will become breathless and then you will feel tired or fatigued. And the third one is a chronic respiratory problem where you overexert. Then you become breathless and then you become fatigued. Okay, so
Yes,
at least one cause of each you should know. Okay, here you are having a past history of all blood transfusion, etc. So you know that it is primarily anemia related.
yes, ma'am.
Okay, so that is one. There is a second in the summary. You said there is a left ankle swelling since 9 months. So it has never been there for last 11 years.
Yes, ma'am.
It is the first time it has come, correct?
Yes, ma'am.
Yes. So on the basis of history and whatever questions you ask the parents, are you able to have some differential diagnosis of this left ankle swelling?
Ma'am, first differential diagnosis is the patient is having hemolytic disease, that is he requires multiple
Right
transfusion.
now, can you concentrate on the left ankle swelling?
Yes.
So if an 11-year-old comes to you with left ankle swelling and you know he is taking blood transfusion for a long time,
Yes.
how
So
will you approach that left ankle swelling? What will you ask? What questions will you ask about that swelling?
I will ask about the incidence that trauma, the intensity of the trauma. If um, it is a trivial trauma or some major accident was done, uh, to rule out the uh, osteoporosis or the bone the thickness, cortical thinning.
So this is swelling, isn't it?
Yes.
It is a unilateral lower limb swelling.
Swelling.
First thing what you should ask is what? Is it painful or
Yes,
painless?
painful or
So
painless.
yeah, you should have told us that this is a painless left ankle swelling. Or is it painful?
Ma'am, antalgic gait is present there. It is a painful.
Did you ask?
Yes, ma'am.
So did the child tell you? It's a 12-year-old child, so they can communicate with you, isn't it?
Yes, yes, ma'am.
So painful.
Yes, painful swelling.
So when you give a onset duration progress, you should pick up left ankle swelling and give all the details. Okay, what you were talking about osteoporosis, etc., means the child has to end up having a fracture there, isn't it?
Yes.
So fractures causing ankle swelling is different. It will not cause a fracture at the ankle, isn't it? It might be above bone or below bone. This is a swelling of the joint, or is it a swelling on the bone? That is what your history has to differentiate.
Different. Swelling of the joint.
Yeah, it is a joint swelling,
painful?
isn't it?
how painful it is? How will you grade the severity of the pain, or how will you assess how bad is the pain?
Sir, to assess the pain, there is a scale that measures from 1 to 10 with
Suppose you have a swelling, somebody has an ankle swelling. What can he do? What can he not do? This boy.
yes.
Can he
He is
dance?
able
Can
to
he walk?
walk with that painful limb, but not able to run or not able to put all the weight on that limb, sir.
See, whenever you take a history, every symptom of the child has to be explained by you on the history, and then only you will go for examination, isn't it? In your summary, we are not able to take that, because when I was listening to you, you said this child has easy fatigability, which is progressive. There is increasing pallor, which is there, or
Yes,
paleness,
ma'am.
reduced appetite, poor weight gain, etc. All those things are there. So in this admission, even if you know that this is a chronic transfusion dependent anemia, what is this episode in addition to the regular blood transfusion? Okay, because it will give you a differential diagnosis. Your DD should be present here only. A unilateral swelling of the joint, which hemolytic conditions or chronic anemias cause it. Keep on thinking about it, writing it down. See, I am asking you from
Yes,
the
ma'am.
point of presentation in the exam. For discussion purpose, this case, you already know the diagnosis. So we are not going to achieve much. It is to have that confidence to present in the exam this case and answer each and every symptom. Okay?
Yes.
So can you give me 2 or 3 reasons why ankle swelling should be there? One, you said whether history of trauma, fall, and then there is a swelling. Second cause could be what?
Sir, ma'am, there is a unilateral swelling.
Yeah.
12 years. So it can be, and the swelling is painful. So JIA may be the possibility. The swelling is since 9 months.
Yeah, so it is a long-standing
Long.
unilateral swelling. So you thought it could be juvenile rheumatoid arthritis, is it?
Yes.
Yeah, now in your first DDs will always be related to the chronic transfusion dependent anemia. Then you go for the other diseases.
Okay. Then varicose vein.
What about drugs? Any drugs that
Drugs,
can cause
yeah.
painful joint in a child who is thalassemic or blood dependent?
Deferriprone can cause arthralgia, ma'am.
Okay, so you have taken the history, you have the answers over there, that presence of mind should be there. Okay, is there a typical type of transfusion dependent anemia where you will get such 9-month, say there is a swelling in the lower limb?
Anemia with swelling.
Yeah. 9-month swelling unilateral, and which type of transfusion dependent anemia will be more with it?
Plastic anemia, ma'am.
Yeah. What is it? Sorry.
Plastic anemia or RBC depletion.
Okay, can you
Will it
just
be
name?
painful?
Sorry, can you just tell me which are the transfusion dependent anemia which you commonly see?
Plastic anemia, pyruvate kinase deficiency anemia, thalassemia major.
Yes, yeah.
In case of severe sickle cell thalassemia.
Yes, so in sickle cell, do you get swellings like this or chronic infections which are
Yes.
associated with a type of
Yes.
chronic anemia?
Yes, ma'am.
Which one?
Uh,
In sickle, isn't it?
It is due to sickle crisis.
Yeah. Is there some chronic infection which sickle cell patients are more prone to, where bone is involved more?
Osteomyelitis, ma'am.
Very good. Okay, so you know all the answers. Only thing, it has to be brought out like this, isn't it? So there is a drug which is there. Read about the drug which comes, which you already told. So you knew the answer. You said sickle cell. You talked about chronic infections, osteomyelitis. So first finish off all these, and then you go for the other disease which are there. I think Dr. Lisa can add to it, please.
Yes. Since ma'am has covered most of it, ma'am has covered all of it actually, but I wanted to ask regarding the family history. So there is no history of any transfusion or any similar complaints in the family, not even in the extended family,
Yes, ma'am.
and it is not a consanguineous marriage.
Yes, ma'am.
Okay. And another thing is, what is his transfusion regime? That I think had to be mentioned, that whether he's taking every month or 21 days or it is infrequent, and a little mention regarding a pre-transfusion HB also would have helped in this. To call it a transfusion dependent anemia, we will have to know the transfusion regime regarding it. It cannot be 3 months transfusion and we won't be able to call it transfusion dependent anemia.
Yes, ma'am.
So what is his transfusion regime?
Transfusion regime.
Is he taking every 21 days or 28
Yes, yes.
days?
Ma'am, initially, the patient was mother told that the patient was requiring transfusion every monthly when in childhood, one
Okay.
or 5 up to 5 years. But
Okay.
subsequently, the patient require more transfusion.
Yes.
That is at every 3 weeks, and currently is requiring every 15 days with 2 blood bank.
All right. And the HB electrophoresis for other siblings have been done.
Yes, ma'am.
All right.
All 3 siblings HB electrophoresis was done.
All right. Okay. We can proceed further.
Are there some chronic infections? Dr. Pramod Kulkarni sir has asked in the chat box. Are there some chronic infections? The moment you have a unilateral swelling, 12-year-old child, a slightly what we can call as a immunocompromised in the sense requiring frequent PT. So what infections you should rule out with unilateral swellings?
Ma'am, septic arthritis.
Okay, because of? I want a particular chronic infection.
In case of transfusion dependent anemia.
Or
Any
otherwise.
immunocompromised. Yeah, immunocompromised.
Or immunocompromised. Yeah.
Which are the chronic infections you know about? Very common one.
Tuberculosis.
Very good. Okay, so if you get an unexplained unilateral swelling, which sometimes is painful, sometimes it's not, and it's almost 9 months. Okay, so that infections you should keep in mind. Okay, but this child has many other factors to explain it. So after examination, we may be able to tell you. Okay.
Yes.
And all these unilateral, painful but chronic, those DDs should be covered in your no history. There are two important things which you will have to spell out in history. One is talk about the fatigue which is there. The second is the swelling which you are talking about, and the paleness which is there coming on and off. And what Dr. Lisa ma'am has told you, that everything has to be substantiated. When you say transfusion dependent, calculate the transfusion requirement ml per kg per year.
Yes, it is calculated, ma'am.
Yeah, so you tell it to us later on. So that, and the drug related. Okay.
Yes, yes.
Okay.
Also, have you asked the parents if there were any adverse effects in the previous transfusions? That's a very important thing. that should be brought up?
Yes, sir.
Okay, go ahead, please.
Want to go to the examination?
Should I proceed
Yes.
with the mission?
Yeah, we can come back to the history when you summarize the case, but you can go to the examination.
General examination. Patient is examined in supine position, conscious, oriented to the time place person. Pulse rate is 120 beats per minute in right radial artery with high volume, normal force and tension, equal on both sides. Peripheral pulses well felt. Respiratory rate 22 breaths per minute, no respiratory distress. Blood pressure, it is 108/64, that is at 50th centile. In right arm in supine position, saturation is at room air, it's 98 percentage. 8 to 2 examination, severe pallor was present. There is no cyanosis, clubbing, no lymphadenopathy, no edema, no icterus. Hemolytic facies is present with frontal glossing, flat nasal breeze, and malar prominence. Eyes are normal, oral cavity normal, skin normal, abdomen slight distended, genitals normal, spine normal, left ankle swelling present, which is it is not visible to me. Left ankle swelling present, restricted to the ankle with no local rise of temperature and tenderness, present with restricted joint movement.
Tenderness is present or absent?
Tenderness is present, sir.
And there is a restriction of joint movement also.
Yes, yes. Tanner staging, stage 1, genitalia are prepubertal, testicular volume is less than 3 ml, and pubic hair is absent.
Can you tell little bit more about the joint swelling? Where is it exactly? How is the swelling? What is the range of motion that is there?
Swelling is present over left ankle joint and the dorsum of the foot, and patient is not able to extend and flex the ankle joint with painful range of movement.
Do you have a photograph or a video?
Sir, video is not available.
Photograph is there?
Sir, no, sir.
Okay. Sir has asked one question. Dr. Kulkarni has asked one question. Any deformity or any degeneration signs? And how is the feel? How is the gait?
Sorry, sir, I didn't get.
Can you read the chat box? Sir has put a question in the chat box. So sir is asking, is there any deformity? Is there any degeneration, signs of degeneration? And how is the gait?
Gait is antalgic. Patient is able to walk with painful gait. Sir, there is no degeneration signs like ulcer or and the feel of the swelling is it is firm, and there is no deformity, sir.
Okay.
So all the joint movement restrictions, etc., they are all because of pain, swelling. Is that what you want to tell us?
Yes, ma'am.
Yeah. Is there on palpation some feel you got bogginess, softness, or is it like a fluid that has got collected, or is it a soft tissue swelling which is there over the joint?
Ma'am, it is like the soft tissue swelling. There is no bogginess or
No bogginess.
no the free fluid.
Okay,
Right.
we'll come back to it later when you finish all your exam. See, I'll tell you one thing. Everybody knows the diagnosis in this patient.
Yes.
Okay, so we are not going to make very heroic things there. Now, in your exam, there will be nothing asked to you about anemia. Everything will be on that ankle swelling. So you have to be mentally prepared for such situations. Okay.
Yes. Yes. Ma'am.
All right, it's a diagnosed case. So now we are looking at how you approach a chronic patient with anemia and a diagnosed condition, but coming to you with a chronic 9 months, say, joint swelling.
Yes.
And it might go to a rheumatology case also. Okay, so you
Yes.
have to be mentally prepared. Examiners will not ask you questions what you want. Okay,
Yes, ma'am.
you should be prepared. So let's go ahead.
Anthropometry weight is 22 kg, less than third centile. Expected weight is 39 kg for 12 years. Height is 120 centimeter, less than third centile. Expected height was 148.5. Upper to lower segment ratio is 1.06. Arm span is 118 centimeter. BMI is 15.36. That is from 10 to 25th centile. Head circumference is 55 centimeter normal. Interpretation, patient is chronically underweight and stunted.
So what are the likely causes for underweight and stunting in this particular patient?
In the poorly managed case, ma'am, with chronic transfusion, inadequate ventilation,
Mhm.
and there is also iron deposition in the all endocrine system, pituitary gland, pancreas, gonads. So hypothyroidism, parathyroid gland, increase in hyperparathyroidism. So chronic stunting.
Yes, very good. Now you just have to be little organized, okay? You
Yes.
already have taken history. You know the child is nutritionally deprived. There is calorie and protein deficiency. So that one
Yes.
is nutrition. Second is your inherent disease itself.
Yes.
Chronic
Chronic
anemia,
hypoxia.
chronic, very good. Third, you said the side effect of iron overload with all endocrine glands getting affected.
Affected.
So if you tell 1, 2, 3 in an organized manner with explanations for that, then you are very confident to sail through, isn't it?
Yes.
Okay, all right. Is there any limb discrepancy?
No, ma'am.
Okay.
Systemic examination, per abdo examination, inspection. There is no obvious distension. Skin over the abdomen normal. No dilated veins. Umbilicus normal. Fullness in the left hypochondrium. Palpation superficial, soft, non-tender, no guarding and rigidity. Deep palpation, leave 5 centimeter below the right subcostal margin, firm in consistency with round borders, non-tender. Liver span is 12 centimeter. Spleen 6 centimeter below the left subcostal margin, extends down towards the right iliac fossa, extending just before the umbilicus, firm in consistency, and it is grade 3 Hackett classification. This is the photograph of abdominal edge. Percussion, dull note felt on right and left hypochondrium. There is no free fluid. Auscultation, boil sound present normal, and CVS heart sounds are normal. Hemic murmur is present. Respiratory air entry bilaterally equal, clear, no added sound. CNS examination conscious oriented. No neurodeficit. Case summary: 12-year-old male patient with transfusion-dependent anemia, underweight and stunted with hemolytic phases with splenohepatomegaly on oral medication since 3 years of the age, which was irregular, is probably a case of thalassemia major with left ankle fracture.
Can you elaborate little bit on the murmur? You said it is a hemic murmur.
Yes.
How do you know it is a hemic murmur? Why is it not an organic murmur?
Because, sir, the murmur is felt in aortic region, and it is continuous throughout the systole and diastole. And there is no
continuous murmur. It is a continuous murmur because hemic murmurs are not continuous murmurs. So how is the first heart sound, second heart sound? See, what is happening is, as madam said, nobody is interested in thalassemia, isn't it? So if you are the third or fourth candidate presenting a thalassemia case, examiners will ask you everything except thalassemia. So I'm very interested now in this cardiac murmur. So you will have to tell, how do you identify organic murmur from a functional murmur? Or why are you saying this is a hemic murmur? What is the grade of the murmur? Where is it best heard? Is it radiating, conducting?
so grade of murmur is grade 1 or 2, sir. It is barely audible on with stethoscope.
Okay.
And it is not radiating to posterior interscapular region. And there is no heave or thrill.
Okay. Go ahead, next.
Ajit, you have written your transfusion dependent anemia, no? So
Yes.
you said you have calculated, isn't it? So what is the transfusion requirement per year?
Sir, ma'am, for this patient, it is 217 ml per kg
Per year.
per year.
Per year. So what
Per
could
year.
be per year?
Per year, yes.
Yeah. So what are the different causes now for this? Is it in the excessive range or it's a normal range requirement for a 12-year-old child?
It is in the excessive range, ma'am.
Up to how much is taken as a normal
to-
requirement of a thalassaemic child?
Up to 200
200.
kg per year.
200. Okay, so suppose you take 200. Now, why have you written transfusion dependent? What happens if you don't transfuse, or what happens to the child before the child is due for the next transfusion?
Ma'am, if patient is not transfused, there is a paleness all over the body. Patient, there is decreased appetite. Patient feel fatigability and
Okay, so you know that now
and
this,
finally failure.
yeah, this should have come in your history.
Yes.
When you write past history, that every time the patient is due for a transfusion, the child looks very pale, becomes breathless, fatigued, and the parents take the child to the hospital. So you, every time you write a case summary, you should have explained it in your history or your findings. Okay, so the word transfusion means you're giving blood to the patient. So it is blood transfusion dependent, because every time there is less blood, the child has to be given blood and the child is normal after that for the next 2-3 weeks or 4 weeks. So dependent has to be explained, blood transfusion has to be explained.
Yes.
Okay, and child becoming back to the normal, so-called normal after PT. Okay. It's an anemia, underweight and stunted. You will explain it here, underweight and stunted, probably because of
Chronic
what?
hypoxia.
You have to learn to talk. If you
Yes.
talk, tell it like a story to us.
Yes.
Also, did you elaborate about the hemolytic phases in your
Hmm.
general examination? Because
Yes.
I thought
Yes. Yes, sir.
you have to
There was
describe it in detail.
hemolytic phases with malar prominence, with the occipital and frontal protuberance, and depressed nasal bridge.
How is the dentition of this child?
Sir, oral cavity is normal. Dentition is normal. There is no malocclusion of the teeth or dental caries.
Okay, all these aspects have to be actually told instead of the examiner asking you.
Yes.
What are the causes for these hemolytic phases?
Because of extramedullary erythropoiesis, the facial bone, that is malar prominence, occipital bone, frontal bone, is extramedullary erythropoiesis, elongation of the bone, hyperplasia of the bone.
I have one question.
Yeah.
The 12-year-old child, can this case be presented as a known case of thalassemia? Since he is on chelation probably from past 11 years and taking regular transfusion and probably having a thalassemia card also. Hello?
Yes, Dr. Ajit, you want to answer madam's question?
Yes, ma'am. It can be presented at like that also. It can be presented in two forms. That is, presenting complaints with pallor, fatigability, and second form, repeated transfusion is there. So I would like to present with the history from first transfusion. Both way can be presented.
See, this was not a question if it was a 9-month-old baby or an 8-month-old baby. But since it is a 12-year-old child on chelation. Yeah.
So what you should do to get away from an examiner like Dr. Lisa, in your past history, you should say that the mother knows that her child is suffering from thalassemia major. It has been diagnosed at the age of 9 months. And present, the child is on iron chelation and the mother knows the name of the tablet. Okay, you tell it so confidently. The mother has to know everything. Then only the history you will get, not from the case paper or the supervisor, your friendly supervisor. They can get you into trouble in exam. Okay, so you have to be so confident that you have taken it yourself and you can always do it. Okay, that's why I said in the beginning, everybody knows this is a thalassemia case. Now I am going to ask you what is not thalassemia in this patient as far as the history and examination is concerned. What are the pointers in the history which tell you it may not be thalassemia or it may be something else?
I'll help you. The
Yeah.
family history.
Because in family history, there is only one sibling is affected. Other three siblings are normal, and the upper generation are also normal. There is no history of blood transfusion or any disease like blood disease.
Okay.
What about the age of presentation of this child?
9 months, ma'am.
Okay. In India, generally at what age you will see symptomatic thalassemia major coming?
Uh, after,
Yes.
after 6 months, 6 to 7 6 months.
Okay. So what is the reason for this child being coming first time at the age of 9
9
months?
months. Um, because ma'am, the might be the mother notice it later that baby is not gaining weight. He paleness of the baby and
Ideally, if you know the physiology of hemoglobin metabolism, this child should have presented to a doctor at what age
uh, at 6 months,
or earlier?
up to 5 months.
A little early. What I'm asking you is hemoglobin metabolism.
Yes,
Indirectly. I'll not ask you a direct question. What is hemoglobin metabolism? Okay. What is the switch when does the HbF start going down? Your HbA2 start coming, the adult type. So in 90% of the normal children, when will it happen?
It's HbF start going down at 3 months, and HbA is start coming at 3 months of age. They
Okay.
cross over between them.
At birth only, no? Within 1 to 2 weeks. Okay, so there is a beautiful graph in Nelson.
Yes,
Just try to understand that graph because that helps you to answer all these questions. So which are the type of thalassemias which can get diagnosed little later? 9 months, 12 months.
thalassemia minor.
Thalassemia minor is never symptomatic.
Thalassemia trait.
That is same. Thalassemia minor, thalassemia trait, they're all the same, or a carrier,
Intermediate.
intermediate.
Yes.
Okay, that's still much later.
It is from 1 to 3 years of age.
Still later.
Sickle cell.
Yeah, so you are having combinations which are there.
Yes.
Different types of sickle thal, one's balancing the other. Okay, you have different types of thalassemias, D, E, etc. So when you have combinations, sickle will thal. Okay, thal intermediates will come much later. Before that, they will start having slight yellowishness of the eyes. The hemolytic phases will be more predominant. The liver spleen will be more enlarged. The anemia will be a balanced one. They can carry on up to 8, 9 years also. Okay, but the hemolytic phases will be much more florid. So if you just read about these clinical presentations, one is the age and how they present, that will be your differential over here. If
Yes.
we get it at 9 months, the presentation was, what was it? Poor weight gain. Isn't it? You said that the mother went to the doctor for
Yes.
poor weight gain.
Yes.
Okay. And you also mentioned that the motor milestones were delayed.
Yes, ma'am.
So these two things are what are present, but they are not perceived. And that is why our people get diagnosed later on. Okay.
Yes, ma'am.
Correct. So a little bit is required for these parts. Now, these hemolytic phases, you said that the bones of the face are involved. Why are the bones of the long bones not involved in this?
Because the hematopoietic stem cells, hematopoietic cells are present in the flat bones, ma'am, after birth in adolescent age group. Long bones, hematopoiesis is done. It is present intrauterine only, and subsequently hematopoiesis uh, is changed over to the only in the flat bones.
Are you sure or you want to correct it? The flat bones are always reserved bones, okay, for hemopoiesis. Okay, only when there is too much of stimulus will they start coming into action. Otherwise, most of the hemopoiesis is where it's in the long bones, isn't it? Up to a certain age limit.
Age limit.
Yeah, again in the geriatric population, the flat bones will start coming into picture. And that is why if you look at our grandparents' photographs, okay, look at their photographs when they were young and when they were 70, 80, 90 years old. The facial features will start becoming where the flat bones have started functioning again in that geriatric age group. Okay, so that is it is going on in the long bones also, but in thalassemia, it is ineffective hemopoiesis.
Yes.
It's not effective. So they are functioning, but whatever is coming out of it is not effective. They are dying out, those RBCs. So that stimulates the flat bones, which were not supposed to be functioning.
Yes.
Okay. All right. So a little bit of physiology, anatomy is required over here. There is splenohepatomegaly you have written. So is the spleen much more enlarged than the liver, or it is hepatosplenomegaly?
And the spleen is 6 centimeter and 5 centimeter enlarged.
And liver?
5 centimeter below right.
Okay. Can you describe how they are? Firm, hard, sharp borders. How are they?
Spleen and liver are firm in consistency, having rounded border with firm consistency, rounded border. Yes, ma'am.
Okay, so now you have a liver and a spleen. Is it the effect of thalassemia or is it the effect of the hemosidrosis? Can you clinically differentiate
Yes.
it, or it's not possible?
Clinically.
Hmm?
In case of hemosidrosis, the consistency will be soft.
It's iron overload, no?
Yes,
Hemosiderin is depositing over there. Whereas for thalassemia, the reason is different, isn't it? So how is it? I'm just assessing your clinical skills.
Yes.
Hmm?
Thalassemia, there is extramedullary hematopoiesis.
Yeah.
So the enlargement of the spleen here and liver, and also there is iron overload and deposition of iron in the spleen liver.
Hmm.
But clinically, the consistency.
I'm asking you this because there are, again, we go back to the history. In the history, you should have told us whether the child is on chelation therapy, how much is it being taken, is the compliance good, is it irregular? Okay, if 1 month they are taking it, another 2-3 months they are not taking. So that tells us irregularly chelated patient will have hemosidrosis much more. Okay, what is the next thing you can talk about? The hemosiderin is also deposited in the skin. If the photograph you showed us at 12 years, is it this child's photograph?
Yes, ma'am.
So the skin is nice. It's nice pink and white in color, isn't it? So no hemosidrosis at all. It's angla in color. It's not dark skin. It's not dark brown. If you look at the abdomen, The abdomen photograph was looking as if there is no blackening of the skin, isn't it?
Yes.
So we take it that the compliance was good. Somebody was adequately looking at the milligrams per kg dose. As a MD student, you should also find out whether the number of tablets the mother was giving or the parents was adequate or it was inadequate dosing. Dr. Pramod Kulkarni sir has written in the chat box, if the child was well chelated and well transfused, why are there hemolytic faces? Okay, so you have to substantiate each thing what you are talking, all right?
Yes.
So the firm, hard, sharp borders is the feature of a not so well chelated hemosiderotic liver and spleen. Okay, if you palpate a well chelated patient, well transfused, well taken care of, in fact, they will not have a enlarged liver or a spleen. And when you have all this going on very well and still you have a spleen and liver, then it could be combination thalassemia, sickle thalassemia, other diseases, etc. Okay. Is this child getting recurrent infections?
No.
Never hospitalized for infections as such.
No, ma'am. He is hospitalized for only blood.
Blood transfusions. Okay, can you show us the last slide again? Your summary slide. So the splenohepatomegaly has to be told in detail. Then you are supposed to look at other chelation, hemosiderotic changes if there are any. Oral medications, if you buy now, you know from the history and the mother tells you the name of the drug, you can always tell that. Okay. And whether the dose is appropriate or not. You know the weight of the child, the mother will tell you the number of tablets, you know the strength of it, and you have to say. So that has to come here, and you have written irregular, isn't it? So this should have come in your compliance history of medications in the past history, past medical history.
Will you ask how
How can you
Yes, sir.
how will you know? Suppose the mother doesn't know the name of the drug or what drug is being given. How do you know that it is a chelating agent?
Because special instruction are given to the child mother that it should be taken on empty stomach early morning. It should be taken in a glass container with non-metallic container.
Any change in the color of the urine?
I can read.
So the special instruction will be it should be taken empty stomach early in the morning in a non-metallic container and
do not stir with metallic spoon also.
And to be drunk within 3 minutes of mixing it.
Yes.
Yeah. And after that, half an hour, after that half an hour only you can have it. So this is one point of it. Can you know the iron chelators based on how many times the child is taking it or the method it is taking it?
On method subcutaneous or intravascular, that is desferrioxamine, oral deferriprone and
yeah, so basically Desirox is OD and
Desirox.
rest of all is TDS. Okay. Will there be any changes in what sir has asked, that will there be any urine color changes if certain chelators have been used?
Case of deferriprone, which is excreted in the 80% excreted in the urine, high colored urine.
So now we have a case summary. How will you proceed with this case?
Ma'am, this patient is having hepatomegaly, that is 5 centimeter with huge splenomegaly with hemolytic phases, and the patient is not taking medications also since the last 2 months, and there is history of irregular taking medication. That patient was not having taking medication for at least 4 months a year, and so we have to counsel the parent, and also there is a requirement of more uh, uh, blood bags, that is 2 bags every 15 days. That is transfusion requirement also is increased. So it's suggestive of the hypersplenism, that is the requirement of the blood transfusion, increase in splenic size. So we should counsel about the splenectomy also.
First, we will find a diagnosis. No, this is a probable case of thalassemia major as per the summary.
Okay.
So before counseling, we will have to know what we are going to counsel. So how are we going to proceed with the case?
On the CBC count, ma'am.
Yes, and
Blood count. We have to see HB, TLC count, platelets count, RDW. To look for pre-transfusion HB, what is the blood, the HB of the patient. It is transfused adequately or inadequately. If pre-transfusion HB is below the 10, 5, we have to check for hemoglobin concentration. We have to check for other the cell line decrease, that is the WBC count or platelet count declining. Biocytopenia, pancytopenia is there.
Okay, then
Menger's index.
Okay. Any other test you want to do?
Ferritin level.
Okay. Will you like to do HB electrophoresis for a diagnosis?
After 12 years of transfusion?
Your is a probable case of thalassemia major. It can be sickle beta also, which might not require a regular transfusion. Because I've already asked you that the 12-year-old child will come with a thalassemia card. Correct. And if you do not have a diagnosis of thalassemia major, then you will have to prove it is a thalassemia beta homozygous, right? It can be beta Punjab, it can be beta Iran.
For that, we have to stop the transfusion of 2-3 months, and HB electrophoresis. Better than that, molecular diagnosis can be done.
3 weeks of transfusion history is okay for an HB electrophoresis. And if the HB electrophoresis is not very conclusive, you can go for a genetic test. Okay. So how will you like to, okay, once the diagnosis has been established, how will you like to treat this child?
Firstly, adequate maintenance of adequate HB, that is more than 10 for proper growth and development of the child. And second, to avoid iron overload, chelation therapy should be there. Proper calorie intake, supplements of the micronutrient like calcium, zinc, and regular blood transfusion depending upon the symptoms, and a regular monitoring for complications of iron chelator,
Okay.
and the psychological counseling of the patient and family.
All right. Any special kind of blood you want to give in thalassemia?
Leukodepleted blood, ma'am. And the extended RBC, extended screen for RBC antigen.
Will you like to give fresh blood in this child?
Yes, ma'am.
How many days old of collection?
Up to 12 days we can give, but as early as fresh is.
We usually give up to a week only, and we will like to give a leukodepleted net tested blood in the child.
Yes.
How much quantity will you like to give the child every transfusion?
15 ml per kg.
15 to 20 ml per
ml
kg.
per kg.
Imagine this is a 8 or 9-year-old child who has been coming to you 2-3 times. See, I'm going to ask thalassemia because you have studied thalassemia and this is a thalassemia case.
Yes.
And where if this child is come 8 to 9 month old, when will you start chelation therapy for this child?
8 to 9 months, after 2 years or after 10 to 15 transfusion.
Okay. And the ferritin level goes
Ferritin
up
level more than 1000.
Yes. How frequently do we check ferritin level in thalassemia for this child, if probably?
Every 6 monthly, ma'am. If there is every 6 monthly, and if there is involvement,
Every 3 to 6 months we will.
3 to 6 months.
In multivitamins, will you only add zinc and calcium? You won't add folic acid?
Yes, folic acid also.
Yeah. Any specific dietary advice will you like to give this child in your psycho or social counseling?
Dietary advice. Avoid the iron-rich supplement, iron-rich food.
Correct. And
take the daily requirement of that much calorie per kg.
Okay, I'll make it a little, I'll just give you a hint types. Any specification regarding tea or coffee for thalassemics?
It's hampered iron absorption, so can be given after a meal, tea or coffee.
So we usually give them black tea or black coffee within 20 minutes after food. Yes. Because of tannins which is present in the tea. Okay. Okay. I think too much of thalassemia. Ma'am, any other questions you want to ask?
No, I will ask like an examiner, MD. You have to teach them, but I will ask the question you teach them.
Okay, ma'am.
Okay. All right. See, I am still interested in that left ankle fracture. How did you know there is a fracture? You have given in your final diagnosis, this is a fracture. So in exam, I will ask you, how do you know clinically there is a fracture?
Clinically, ma'am, there is swelling, decreased range of movement, inability to do work from side, and there is a local rise of temperature.
Yeah, but why is it going on for last 9 months? A fracture is supposed to heal and 6 weeks is more than enough.
Yes.
And the child was in a cast according to your history. So why is there a swelling still there and it's still painful, movements restricted? What's going on there?
Because due to chronic hypoxia, ma'am, there is proper healing, and patient also was advised every time in admission that the applied on the fracture, but they every time they refuse. They take on blood transfusion, and So no proper treatment for the ankle swelling, lost follow.
Now, this child has got anemia, fatigue, a hemic murmur, and a unilateral joint swelling. Why is this not a rheumatic heart disease?
Fever is not there, that ma'am.
What is not there?
Instead of fever,
Fever is never there.
yes, no fever.
Okay. What other thing? It's a rheumatic heart disease. The child has already got an established heart disease. There is no rheumatic fever, but there is a rheumatic heart disease.
And the joint involved is only single joint, ma'am. There is no multiple joint involvement.
Unilateral
Unilateral.
meeting. So like this, you are supposed to answer. It may not be relevant to the case, but if you are asked a question, you should be able to defend yourself. Now that why it is not, isn't it? Why this is not tuberculous joint?
Tuberculous joints. There is no history of it. Can be tuberculous joint, ma'am.
That's why I'm asking you.
Yes, because the since the history of fever is not there. The history of tuberculous involvement, fever should be there. History of poor. There is no history of weight loss also. History of poor weight gain is there, but no history of weight loss. No history of TB, active TB contact. No history of no history of cough, cold, chronic cough.
Okay. Did the mother tell you in the history that there was an X-ray taken and a fracture was there? It was told to her. Has she told you in the history?
At the time of yes, ma'am. The patient, my mother told that 9 months back the patient was found and cast was applied over that.
Okay. Because whenever you have such type of injuries, and if you are dealing with a patient of sickle thal, if you don't think about it, actually there might be a trauma there, and with hypoxia, you will start developing osteomyelitis, which is very common. Okay. So you can't just say that this is a non-healing fracture. Look for evidence of infection at that point. That is the common site for infection, lower limbs around the ankle. Okay. And still you should always, like how Dr. Lisa ma'am has told you, you need an electrophoresis if you are in doubt that you are not missing out a thalassemia major versus sickle thal.
Yes.
That is the main reason. Is there any other reason why a patient of transfusion dependent has osteoporotic changes and easy fractures? What are the different reasons for it?
First is the extramedullary hematopoiesis in both cortical thinning. Second is endocrine involvement. Parathyroid gland is deposited with extra iron, so hyperparathyroidism is there.
Yeah.
So cortical thinning and fracture, osteoporosis.
Okay. So usually they have osteoporotic, easy fragment, fractures prone.
Yes.
Okay, he's a 12-year-old. Is he going to school?
Currently is not going, but the patient is going to school.
He is. Which class
Yes.
is he studying? This is a part of your personal history,
Yes.
schooling, education, isn't it? You can't miss out on that.
Yes.
Very important. What is RBSK?
राष्ट्रीय बाल सुरक्षा कार्यक्रम.
सुरक्षा है का?
स्वास्थ्य कार्यक्रम.
Swasthya Karyakram, isn't it? Is
Yes.
thalassemia, sickle cell a part of the RBSK?
Yes, ma'am.
Yes, so you will have to know the benefits. What are the benefits this child as a person and the family as a whole benefit from the government? What are the benefits for these children?
Government supplies, ma'am. The government gives them disability certificate, and there is a concession in buses and railways for traveling. Uh, in school, education is free.
It's not free. In government schools, it is all free.
Yes.
For girls, it is all free. Okay, so the schooling is free actually. They can get benefits. There is a right to education, RTE. Under that, these children can get admission even to the English medium schools, higher paying months. There is a certain quota kept for such patients where the disability certificate can be of use. What are the benefits for the parents of a thalasssemic child if they have a disability certificate?
Parents, the government do parental screening also.
No, as of today, no. Certain states, health is a state subject. So some states have done it, some do not. Is there a screening program in Maharashtra, thalassemia screening program at birth?
Under national mission of health, there is a screening program. I'm not aware of that. It is in Maharashtra or not.
Where are we appearing for exam?
Maharashtra.
Maharashtra, na?
Yes.
So just read about everything about thalassemia major, hemolytic anemias, everything for the state first and then for the country. Okay. Are you appearing which exam? MD, isn't it?
Yes, ma'am.
Ajit? Yeah.
Yes.
Otherwise, DNB students have to know what are the different types of anemias all over the country. And if you
Yes.
are from Maharashtra, you will appear in Delhi, Gujarat, somewhere. So you should know about it, what is happening in other states. Okay, the parents can get income tax exemptions up to a certain limit if they have
Yes,
a
yes.
certificate of disability for thalassemia or any other. Okay. Yeah, so there is two, three things. You should, one is right to education, RBSK, then the Mahatma Jyotiba Phule Yojana.
Below
Do you
Yojana.
know
Yes.
MGPGY?
Yes,
What are
ma'am.
the benefits under that for thalassemia?
They give the free medication, chelators. There is scheme for thalassemia and MJPGY.
How much is the package?
10,000, ma'am.
10,000
Yes.
per visit.
Per visit for 7 days.
Yeah, and for the whole year, the whole family is insured for 1.5 to 2 lakhs for any admissions to a government hospital or an empaneled hospital. So if the child has a fracture, that fracture also has to be treated free of cost along with that thalassemia package if it is related to thalassemia, osteoporosis, etc. All that. Okay, what is the treatment for thalassemia? Is
Cure.
there a treatment or cure for thalassemia?
Cure. Bone marrow transplantation, ma'am. And the gene therapy is also there.
Are there clinical trials of gene therapy going on somewhere?
Yes, ma'am.
Hmm.
Up till now, there is only 6 gene therapy has been done. Trials are going on.
Okay. So suppose this child is a sickle thal or a sickle. So what is the usual aim for these patients? who have sickle thal or sickling problems? Are there some newer drugs which have come?
Uh, Along with older three chelators, there is a desferrithiosin and hydroxybenzyl ethyl diamine diacetyl,
Mhm.
and these are two new chelators.
Chelator. So, wow, as a student appearing for exam, I know those names are very difficult to remember. Dr. Lisa, madam, might remember it, but otherwise, just make sure that you know the newer ones, whether
Yes.
they have been approved by the DCGI for use in India or are they only available abroad? Because many of the parents will ask you, isn't it? "Kya Naveen काय आलेला आहे?"
Yes.
If the same case was sickle cell anemia, is there a 2021 March, May, one article has come with 3 new drugs which have been licensed by the US FDA for sickle cell. So read about it.
Yes.
Okay.
Yes.
The aim of this drug is to reduce the vaso-occlusive crisis, and the other one is to increase the HbF levels so that the sickling is reduced. Okay, you might get a sickle case, or the thal case may end up having all discussion on sickle cell anemia. Okay, so there are drugs like voxelotor is there, L-glutamine is there. Okay, so all these drugs have come new and people are using it. A lot of clinical trials in pediatric age group have been going on in the last 5 to 10 years, and some of them will be completed by 2026. Only then they will come into the market. Okay, so a little bit your fourth paper is on recent advances, isn't it? For that you will need it. Okay. So I think from my side, you have faced examiners, 2 examiners. Dr. Lisa was very mild.
Very.
Okay. Yeah, she doesn't want to trouble you, but I think you have done quite well. You have presented it also well. Only thing is, whatever you write in the summary or you end up telling us, each has to be substantiated. And if you take a good history, everything can be explained. Okay.
Yes.
Pediatrics, around 80-85% of your diagnosis comes from history. And while you are taking history, observe the child. That 10-15 minutes, you observe the child, you will not have to examine the child also. So you will never be short of time. No? Only 5 to 10% of the time that child in the exam allows you to examine. Most of the time they are crying. Okay, so your diagnosis should be from history and observation and a few focused examination. Okay, there is a lot in these type of cases and the questions can go anywhere. Okay, there is one more thing. This child has been on regular transfusions for last 11 years.
Yes, ma'am.
Yeah, so what complications can occur because of that?
Chronic transfusion, first is there is a iron overload, and iron overload, all complications, the endocrine complications, uh, pancreas, there is the IDDM, uh, pituitary gland involvement, there is
Yeah, so besides the hemosidrosis,
besides the hemosidrosis,
yeah, tell me something else.
transfusion related transmission of infection, that is hepatitis B, hepatitis B, C, HIV infection, cytomegalovirus infection is there.
Is there a national program for hepatitis from the government of India? Triple H.
Don't know.
Okay, read about it. Sassoon Hospital has got a center which is established for diagnosis, viral load of the hepatitis and also the treatment. The medications are given free of cost, hepatitis medicines, if the person is eligible, adult and pediatric. Okay, so read about that national program. Hepatitis B, C, both are included in that. Okay, and the other, of course, other hepatitis are. All right, and the drugs are also available. Anything else? Now, suppose the patient is keeping on getting these blood transfusions, and one fine day the patient starts having reactions, and every time the child comes, the patient receives blood and has a reaction. That means what is happening?
It can be happen due to alloimmunization, that is antibody produced against the RBC. So reaction occur after every transfusion. There are two types of reaction: early and delayed. Delayed after 10 to 14 days, and early at the time of transfusion only. So we have to stop the transfusion. We have to collect one EDTA bulb, 2 ml, one 3 ml plain bulb, report the case to the blood bank,
Yes.
and the should be done.
What do you do with the blood bag?
Blood bag also repeated sent to the blood bank, ma'am.
Yes, good. Now, what should you do? Well, you have done all these things simultaneously. Other residents should do what?
Secure intracath, or if intracath is present, give intravenous IV fluids.
Yeah, you have to keep the kidneys functioning.
Yes.
Yeah, the urine output should never stop. Otherwise, they go into renal shutdown. Okay, so all this, it's a teamwork which has to be done, and all these transfusion reactions are totally preventable. The mismatch which occurs is all iatrogenic because of our mistakes.
Or lack of.
Yeah, either in the blood bank or at the site where we are actually using it. Okay,
Yes.
so you need. Can you develop autoimmune disorders following chronic transfusions?
Autoimmune antibodies are formed. That is only I know.
Okay, read about it.
Yes.
All right, because this is going on for 11 years, patient is being transfused. So you need to keep that in mind over a period of time. What are the long-lasting effects of these alloantibodies which are being created in the body, and what are the target organs for them? Okay, what are the eye problems in a thalassaemic child who is on chelation?
There is the visual
which drug is known to cause what problem, and that's why you have to monitor the
yes.
eyes, no?
Desferoxamine causes auditory and hearing problems. Deferriprone causes granulocytosis and arthralgia. Desferoxamine causes deranged creatinine level, deranged LFTs, liver enzymes, and
Okay, read about posterior capsular cataracts. Which medicine is known to cause it? Or which it is a side effect of what in a thalassaemic patient? Okay. All right. What are the psychosocial problems you know about thalassemia? Is a 12-year-old child. Which are the problems you anticipate? Is almost approaching the adolescent age group, isn't it?
poor quality of life, ma'am. Patient is every month he is admitted for 1 or 2 days, and there is social stigmata that this family of this child is having something chronic problem. He is admitted repeatedly. So psychological support to the child should be there. He also feels that I'm different from other children that is in the school or uh,
Okay, there is
in
lot
society.
of there is
Yes.
lot of bullying in the school because
Yes.
they have these hemolytic faces. They are usually the shortest children in the classroom. They may
Yes.
be very clever, they are very smart, they pass all their exams. But the skin color, the short stature,
Yes.
and the hemolytic faces are used to bully them. Okay,
Yes.
so it's a job of our doctors and us that we get in touch with the school. If you find suddenly your thalassaemic child is not going to school, find out the problem.
Yes.
And they have got lot of benefits which the parents need to be made aware of. Okay, and they can benefit. Many of our children have gone on to become doctors, engineers, IAS officers. They are doing very well, even in India. Only thing they require not just medical support, but also many other,
Psychology.
yes, okay, for them to really do well. But of course, the family also matters if they are not interested. Then it becomes very difficult. Okay. And you
Yes.
should also know a little bit of antenatal diagnosis.
Yes, ma'am.
Okay. How is it done? Where is it done? What is the cost of it? All those you can.
Yes.
So I think from my end, I will stop here. Dr. Lisa, ma'am, you want to ask any questions? Dr. Sanjay Nathu is there. Others are also there.
I don't want to ask you anything. I think madam has almost given you an MD exam demo, like a little tougher demo. But I just want to mention that whenever you will get a thalassemia case or a sickle case in your exams, definitely a short or something like that, short case or something, the case presentation should include your transfusion regimen and the chelator, whatever it is, from when it was started and current, how much it was started and how currently what he's having it. And the transfusion regimen should also have how many bags he is taking, what is the interval of transfusion, as well as the pre-transfusion HB he is maintaining. And because all this will be important for you to tell it, was it a regular transfusion or an optimal transfusion, which is very important. And another thing is in your case summary also, you will have to mention the chelator dose and the method of it, how he is taking. Okay, that is like 20 mg per kg or 30 mg per kg. So we will also note that if it's an adequate dose, we are treating it properly or we need to optimize it. And mostly, if the Viva goes further, you will also have to tell that you will also do a parent HPLC.
Parent screening.
So yeah, to know if it was really sickle beta, because if it is sickle case, you will not comment regarding the diagnosis until and unless you have a sickle report of the parents in your hand. The same thing is very, very important. So parents HPLC also you will have to mention. And for if the question goes up to the proceeding of the case, then for the investigation, CBC will be done monthly. LFT, RFT, if normal, 3 monthly with 3 monthly ferritin. And for yearly, DEXA, MRI, 2D echo, all the thyroid hormones, growth hormones.
Yes.
And from the question of government aided scheme, whatever madam has told, and an SBTC card, because blood is also given it for free. And probably by next month, the government will also start giving Luco filters free of cost to all the government centers because that tender has been passed. So that will be the whole comprehensive case discussion with the comprehensive thalassemia care. Just one last question, Alex. A very mild, because I think you have studied 48 hours of thalassemia. So
I
you
would
will
like to
obviously
ask Dr. Ajit, do you have an X-ray of this patient?
Old
Do you
X-ray.
have the X-ray of the
Yes.
ankle?
Yes, sir. But not now.
राजेश, मला वाटतं ना आता डॉक्टर अजितला स्वप्नात पण येतो अँकलच दिसणार आहे. Ankle X-ray.
Yes.
If you were appearing for exam, I would have taken only ankle fracture. No thalassemia.
Yes.
Yeah, one more
Sure.
thing. What about testing for HIV, HBsAg, and HCV? How frequently will you do it?
Every 1 year, sir. Nearly.
Okay. And lastly, uh, I think you talked about electrophoresis, parents HPLC. You've already spoken about it. What is the life expectancy if properly managed?
If properly managed, the patient can be live up to the fourth, fifth decade, sir. There is
Yeah.
no.
Okay, so near normal, you can say.
Yes, they are not.
And also read about criteria for BMT. Not all children with thalassemia are good candidates for BMT. So read about criteria also. Anything
Yes,
else,
there is
Dr.
no.
Lisa or Dr. Kinikar ma'am, you want to ask anything?
I want to know whether a thalassemic girl who has been managed beautifully by Dr. Lisa madam, now she wants to get married. She's fallen in love.
Yes,
What,
ma'am.
what is your counseling?
Sir, ma'am, first, she can be get married. We screen the. It is she is thalassemia major or minor?
Oh yes, thalassemia major, taking treatment with Dr. Lisa ma'am. She has beautifully managed. She is now around 27, 26 years and she wants to get married.
She can get married and can uh, get pregnant also, ma'am, with proper uh, uh, precaution. We have to give IV desferoxamine for to decrease iron overload. Also, we have to test antenatally the further child is having thalassemia, major, minor, or trait.
What is the child likely to have? The husband is normal.
And husband also,
Electrophoresis is normal.
if we should test her husband also that he is normal or not. If he is thalassemia free, then is a if there is girl child, she will be having a thalassemia minor. And if there is a boy, it will be having thalassemia carrier. Both all children will be having thalassemia carrier, ma'am. Sorry. Yes.
Okay, because she's homozygous, isn't
Yes,
it?
homozygous.
Yeah, and the husband is a normal person. Okay, so
Yes.
they are during pregnancy. What happens to the hemoglobin? It will drop, isn't it?
Yes, yes.
Requirement is more.
More.
Okay, at the same time, you don't want the mother to be iron deficient also.
Yes, ma'am.
At the same time, you don't want to give her the chelation drugs which have effect on the fetus.
Yes.
Okay, so you will read about the safe drugs during pregnancy, the safe regime of blood transfusion, okay, and how you manage these mothers during the delivery and during the entire antenatal period.
Yes.
Okay, lot of counseling support is required. There are higher chances of preterm labor or even loss of the fetal losses are also known. So you need to be careful, but they may require some hormonal support also that time. Okay, so all this now, this is where thalassemia girls in India are also getting married and having children of their own. Though they are carriers, they don't mind, but they can have that motherhood also. Okay, so this
Yes.
is all possible. So read little bit about that, and also screening. All husbands and all the boyfriends should be screened during antenatal period.
Yes.
Okay, if they are planning for pregnancy or getting married, you should insist on the doing the testing and counsel them accordingly. Okay. And of course, you have antenatal diagnostic facilities now available. So
Yes.
that could be made use of. Okay. And a little bit knowledge about prevalence of thalassemia in India, in different parts of India, the different communities which are there, and what measures can be taken. Okay? All
Yes.
right. I think so. That's fine. Dr. Rajesh, no more questions. He's done well.
Okay,
Exam
great.
pass ho gaya.
So,
Yes.
yeah, Ajit, you presented quite well, and I think Dr. Tushar Deshpande has quite ably guided it. And I would like to thank Dr. Kinikar Madam and Dr. Lita Madam for their expert opinions and guidance that they have provided. And
Rajesh, can I make a comment?
yes, please.
I think it was a master class in how.
Absolutely.
Sanjay, Dr. Sanjay sir, your voice is gone there. Can't hear you.
Am I audible?
I heard him partially.
No.
Yeah, he said it is a master class. So
Yeah, absolutely. By how to take a case. So
Yeah,
even if
so
a case
very
of
nicely done.
thalassemia is there, the student should not take it for granted. That thalassemia is going to be very straightforward. So the case can go in various directions, and that needs to be kept in mind by the student. And that was very beautifully demonstrated by Kinikar ma'am.
Absolutely. So I thank all the participants on behalf of IAP Pune. I have an announcement to make. So last 3 sessions, we were doing the sessions on Thursdays. So after the next session, that is after 14 days, would be on Wednesday. So we look forward to seeing you in a couple of weeks again on a Wednesday. Thank you very much. Thank you, IAP Pune.
Thank you.
Thank you.
Thank you for inviting me. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Yeah, thank you.